Crisis in Healthcare movie night. We are going to talk about disparities in chronic kidney disease. We are very privileged to have Teresa Viller on with us tonight. She is a certified nephrology nurse who works in a in-center hemodialysis unit. She's the chair of the Kentucky Nurses Association Professional Nursing Practice and Advocacy Cabinet. She serves on the KNA Board of Directors and is on the American Nephrology Nurses Association Health Policy Committee. Teresa has a master's in Science of Nursing from the University of Kentucky. She has a Master's of Science in Community Health Administration and Wellness Promotion from California College for Health Sciences. She has a bachelor's degree in nursing from the University of Illinois, a diploma in nursing from St. John's School of Nursing, and an Associate of Science from Lincoln Land Community College. So please join me in welcoming Teresa tonight as she walks us through chronic kidney disease.
Hello, everyone. Welcome. I hope that you had a chance to watch the documentary, I Didn't Know. Some of the information that you're going to find in this presentation is going to be a little different. I Didn't Know is from 2018, so the information you're going to get tonight is more up to date. As you know, or as you'll find out, chronic kidney disease is a public health crisis. It costs this country a lot of money every year to take care of these patients. There's a lot of disparities in care and in transplantation. And I'll talk a lot about transplantation here because it is the gold standard for treatment of end-stage renal disease. Okay, those are our objectives, and those were listed on the website, so I'm not going to go over those. One thing I do want to talk about is, before we start the discussion, is race. I'll talk a little bit about racism as well, because those are some underlying factors in why that we are seeing some of the disparities in chronic kidney disease and end-stage renal disease. Race is a socially constructed concept. There is no specific gene that can determine race. And we are just now questioning whether it's of advantageous use in healthcare. And we'll particularly talk about that when we talk about glomerular filtration rate, which is a test that we can calculate to see where a patient is, what stage they're in their chronic kidney disease. We also need to talk about association versus causation. So racial differences in diseases are from the effects of racism and not race itself. We all know that chronic and cumulative effects of stress is associated with racism, can lead to health disparities. And especially the Black population, who we are seeing, they are over-policed. They have some issues with the way they are treated and policed. And then we'll also talk about different aspects of racism. Also, race correction in current clinical algorithms and guidelines may lead to under or overestimating risks for certain racial groups. And again, we'll talk about that when we talk about GFR or glomerular filtration rate. And algorithms currently use existing data, which can include racially biased data. So we're already putting these patients at a disadvantage. So there are different types of racism. There are structural racism, there's some rules and regulations and laws that reinforce racial inequities. And even when we try to make rules, regulations, and laws to address disparities, we still find that because of implicit biases, we're still having problems with inequities due to race. And we'll talk about that a little bit when we talk about transplantation. Institutional racism, those are practices within and across institutions that disadvantage racial groups. We also have cultural racism. Those are identifying groups based off of their language, religion, norms, or customs. We have discrimination, which is unfair treatment of people and groups based off of certain characteristics. So the way we treat people based off of their color. And then we have implicit bias. So that's automatic and unintentional, but it's still very harmful. And it's something that is ingrained in us because of the four issues with racism that we just talked about. Okay, so we're going to talk about some social determinants of health. We're going to spend some time on this slide because there are a lot of issues that create disparities within this disease, within healthcare itself, but particularly within chronic kidney disease. So some social determinants of health include economic stability, neighborhood and physical environment, education, food access, security, healthy options, community, safety and social context, and healthcare itself. Within economic stability, worsening neighborhood poverty has been associated with decreased kidney transplant rates. And again, you'll hear me talk a lot about kidney transplant because of its gold standard use for the treatment of end-stage renal disease. 20% of Blacks are below the federal poverty level as compared to 9% of whites. Higher socioeconomic status is associated with increased access to kidney transplantation. Lower income and less education were less likely to have been under the care of a nephrologist before starting dialysis. And we already know that if you aren't referred to a nephrologist early, that increases your morbidity and mortality with this disease. We also note that microalbuminuria, that's protein spill in the urine, which is an indicator that there is already kidney damage, and reduced glomerular filtration rate and end-stage kidney disease are highest in the low socioeconomic status groups. So there we are already seeing in just one aspect of social determinants of health how it's affecting chronic kidney disease patients. Related to neighborhood, housing, walkability. In high crime neighborhoods, people are less likely to get out and walk about. That increases the risk for obesity, diabetes, hypertension, and diabetes and hypertension are the number 1 and number 2 risk factors for chronic kidney disease. We know that Black people are 30% less likely to own their own homes than whites, and that comes into factor when we talk about doing dialysis in their homes. If you don't own your home, you have to make sure that the person you're renting from allows you to maybe alter the plumbing so that you can do especially hemodialysis at home, reconfigure rooms because some of this equipment is large, takes up a lot less space. So that Black people have a less ability to own homes really affects their quality of life and the amount of dialysis that they can get. Rural residents have a lower rate of kidney transplant than urban dwellers. And those living farther away from a transplant center also are less likely to receive a kidney transplant. So that's including your zip code and geography in the disparities that we're seeing in chronic kidney disease. As far as education and literacy is there, and more towards health literacy, 76% of Blacks graduate from high school as compared to 88% of whites, and a higher education and higher literacy level was associated with an increased access to kidney transplant. So you can kind of see how that is affected. Also remember with food and food insecurity and access to healthy options, if you don't have access to healthy options, you're more likely to eat foods low in nutritional value. You're more likely to be obese, you're more likely to have uncontrolled diabetes and hypertension, again, risk factors for chronic kidney disease. Community, safety, and social context, particularly Black families, they want to be more involved in the care of their loved one with chronic kidney disease. And we'll see at the end of the presentation, there was a study done how important it was for their familial support system. And these patients did a lot better when they had that support. And of course, healthcare. 10.5% of Blacks are uninsured as compared to 6.3% of white patients. Patients with VA health and Medicare and Medicaid were less likely to get a kidney transplant. Patients on Medicaid had poorer control of A1C than private pay or even Medicare patients. And again, that's diabetes and that's a risk factor for chronic kidney disease. Those with no insurance were less likely to receive recommended care related to chronic kidney disease risk factors. Again, that's probably because of lack of access. Black patients have a higher rate of high blood pressure and diabetes, number 1 and number 2 risk factors. And Black patients were more likely to progress quicker from chronic kidney disease to end-stage renal disease. And those patients are also younger. So as you can see, there are a lot of social determinants of health that affect chronic kidney disease and the progression to end-stage renal disease. Other causes that, for disparities in chronic kidney disease, these are not as well studied. They're cultural, attitudinal, philosophical, or religious biases. And as we saw in the documentary, one of the doctors talked about how there was less willingness to have living donor because of religious myths. There was a fear that they were being used as guinea pigs. Excuse me. There was a fear that if they signed the donor card, we would be more interested in getting their organs than taking actual care of them. And they were afraid that if they donated their organs, they would go to only white patients. So there's a lot of things here that can lend itself to further research, and we should be actually doing that. Okay, so here's the problem. 37 million US adults have chronic kidney disease. 90% of them do not know they have the disease. 80 million more are at risk for chronic kidney disease. Our Medicare system spends 130 billion with a B on care for these patients with kidney disease. And I kind of broke down the cost for pre-kidney failure. That's education, stages 1 through 3. It costs about $26,000 per year to care for those patients. First year after a kidney transplant, it costs about $24,000 to care for those patients. But patients who are on dialysis, it costs $87,000 per year to care for those patients. So as you can see, it costs this country a lot of money to care for patients with chronic kidney disease and end-stage renal disease. Black Americans make up 13% of the US population, but they make up 35% of people with chronic kidney disease. As you can see from this graph, when patients are in stage 1 through 3 chronic kidney disease, they're about even, and actually Hispanic patients fare better. But once you get into end-stage renal disease, stage late 4 and 5, Black patients are 4 times more likely to have end-stage renal disease than all other groups, particularly whites. Black and Hispanic Americans wait longer to receive a deceased donor transplant, and patients of color are less likely to receive a living donor transplant. So again, Black Americans are 4 times more likely than Caucasians to have chronic kidney disease. And the incidence of end-stage renal disease, you can see the disparities there. 849 million cases per million for Black Americans and 311 cases per million for white Americans. So there's a huge disparity in these patients who have this disease. Black patients also have worse outcomes, and that's related to less blood pressure control, timely referral to a nephrologist, fistula replacement before hemodialysis is initiated. That's you would find that in somebody who had early referral and was actually developing a plan of care with their nephrologist. So we're not seeing those patients get that, and a lot of times it's because they do what we call crash into dialysis. They don't know they have chronic kidney disease. They don't know that they're sick. Then all of a sudden one day they feel really, really bad, show up in the hospital, and they're in kidney failure. Black patients are waitlisted longer for a kidney transplant. It takes longer to put them on the wait list, and they don't receive a transplant. They also don't receive preemptive transplant, and preemptive transplant is you actually get on a waiting list for a transplant because you know you're gonna need one. But you get on the list before you actually have dialysis. And those patients who have preemptive transplant do much better than those who initiate dialysis and then have transplant. So I'm going to talk about disparities in transplantation again, because it's the gold standard for end-stage renal disease. There is an organ shortage. Every day, 12 people die on the transplant wait list waiting for a deceased organ donor. Black patients are 55% less likely to receive a kidney transplant. They don't get preemptive listing. And again, it's probably because they crash into dialysis. So they don't know they're sick. They end up in the hospital and their kidneys are already gone. And 33 to 63% of patients initiate dialysis unplanned. And unplanned means they start dialysis in the hospital without having a permanent access, or actually talking about the options for care or even where they want to do their dialysis. White patients are greater than any other group to receive a kidney transplant. The majority of deceased kidney donors are white. Blood type disparities also are in place. So a type O blood type is a universal donor, but they are not a universal recipient. So blood type O can only receive a blood type O organ, but blood type O organs can be allocated to both O and non-O recipients. So this means that the O type organs are depleted more readily. Blood type Os have a lower rate of kidney transplant, and 70% of Black patients have either blood type O or blood type B, and B is the least likely to undergo transplant. So you can see that with these blood types, it's much better if these patients actually get a living donor. If we can educate people on, actually that they can live without one kidney, they can live perfectly normal lives with one kidney. We just need to increase education. Also remember with the pandemic, we're seeing many more patients being affected with their kidneys and going into kidney failure with COVID-19. And remember, a lot of transplant centers will not transplant an organ without patients having all of their immunizations. And that's because, remember, these patients are immunocompromised because of their illness, but after transplantation, they're even more immunocompromised because of the immunosuppressive drugs that they're on. So they are at a very high risk of developing infections that then can destroy their transplanted organ. So I just bring that up because Black patients are least likely to receive a first dose of COVID vaccine at 57%. So the pandemic itself has created some disparities. We also have paired donation. Paired donation is actually a good thing. So paired donation works this way. Let's say I want to give my kidney to my husband. I want to donate my kidney to him, but we are not a match. And let's say there's a guy named Joe and he wants to give his kidney to his sister-in-law, but they are not a match. So if that was the case, there would be no kidney transplants. However, I am a match with Joe's sister-in-law, and Joe is matched to my husband. So we can pair these donations, and now we can have 2 kidney transplants where we couldn't have any at all. But the problem is, let's say that I live in Lexington, Kentucky, and let's say UK doesn't do paired donation, but Cincinnati does. But I don't have a car. I don't have any way to get to Cincinnati to get the workup, to get the transplant. That disparity right there is because I'm poor, I don't have a car, I don't have transportation. So we need to make sure that we are getting patients to transplant centers that can do these paired donations that can increase transplantation. The US kidney allocation system, in 2014, this system was updated because they were seeing great disparities in who was actually getting transplants. So the change included the patients begin to accrue wait time when they initiate dialysis or join the wait list, whichever comes first. So before, I'd crash into dialysis, it'd take a year and a half to get my workup done. And then I could get on the transplant wait list, and then I would be waitlisted for like 2 to 3 years. Whereas now when I crash into dialysis, that first day of dialysis counts towards me being on the transplant wait list. They also do longevity matching. So they look at 20% of patients who are expected to survive the longest after a kidney transplant receive the 20% of kidneys that are expected to last the longest. And they do this by a numerical measure. And this measure combines 10 donor factors, a lot of clinical parameters, some demographics, but it also includes ethnicity as one of the factors. And we already know that that itself is a problem. There's increased priority for sensitized candidates with high panel reactive antibodies. Those are mainly a lot of women, particularly women who have been pregnant in the past. But there's still variability in transplant centers in who they accept for transplant and which organs they're accepted. So there's a lot of subjectivity still in transplantation. And even after this allocation system was updated in 2014, we are still seeing that Medicaid patients are less likely to receive transplants preemptively, even post changes to fix those disparities. Also, once inactive on the transplant wait list, and that could be a lot of different things that make you inactive. One might be that you were supposed to follow up with your hepatologist because of your hepatitis C, just to get the workup and for them to let us know that you're okay for transplant. If you don't do that, they will take you off the transplant wait list, make you inactive. White patients are more likely than other racial ethnic groups to resolve those issues and get back on the wait list. So we need to do a lot of education with our patients on, one, not letting themselves fall off the transplant list, but if they do, what does it take to get back on it? Okay, so estimated GFR, glomerular filtration rate. It's a calculation that we do to determine where the patient is with their kidney disease. I will tell you that the National Kidney Foundation and the American Society of Nephrology developed a task force reassessing the use of race in GFR. They did a lot of things. They looked at over 100 calculations for GFR, and yes, there are over 100 calculations for GFR, which is part of the problem. They narrowed it down to 26, but initially they just took out race altogether just to see what would happen. And when they took out race altogether, they showed that the GFR was actually underestimating your GFR. So they were saying that your kidney function was worse than it actually was, just taking out a race. Removing race can actually help to increase access to care. So the Medicare system through the chronic kidney disease care has a kidney disease education, which they will pay for. So you bring your patients in, you do education, you'll get reimbursed for that. They also have a nutritional supplementation under the Medicare Kidney Care Program. Because we all know that good nutrition helps with hypertension, diabetes, can help to slow the disease and prevent you from going into end-stage renal disease. One calculation for GFR, which we used to use all the time, was only originally developed in white men. So you can see the problem with that. There are many equations. Like I said, the modification of diet and renal disease equation is the most frequently used. It was also validated in use with Black patients, but GFR estimates and care decisions are not standardized. So that is a problem. Now, the NKF ASN task force did recommend this chronic kidney disease epidemiology collaboration creatinine equation. But they also said that there needs to be a lot more research in taking race out of these calculations. And they recommend also using cystatin C protein. It's a protein that's elevated in kidney disease. The problem with that is not all labs do cystatin C protein, and it also would increase the cost of caring for these patients. So, and there's a consideration that Black and other racial ethnic groups are underrepresented in GFR research. So when we do this research to remove race from the calculations, we need to make sure that they are represented there. So a couple of different things that the task force did recommend was that we eliminate race from GFRs, that we do research on it to make sure that we're getting good calculations, that we do standardize care decisions and GFR estimates, but more importantly, that we're looking at the social determinants of health and how they actually are, contributing to ethnic disparities. Actually, what they said also is just removing race from the GFR could promote healthcare justice. So that should tell you a lot about race and the use in GFR. So removing race from the equation, we already know that Black people are at increased risk for chronic kidney disease. So we need to just focus on chronic kidney disease screening, detection, risk prediction. With these patients, removing race, so we underestimated their GFR, so their GFR was actually higher. So those patients can actually become living donors. So it could increase our living donor pool. The problem with removing race is they were better at the front end, but at the bottom end for end-stage renal disease or stage 5, they quickly moved into that stage. So again, that's why we need to do some research on utilizing GFRs. We need to make sure that these patients are put on preemptive transplant referral. Again, they do much better when they are on the transplant list, get a transplant before they initiate dialysis. What all this means is we need to get the patients into healthcare systems. We need to get primary care physicians to feel comfortable talking with these patients about chronic kidney disease and the treatment options. We need diabetes and hypertension treatment earlier. And we need to prevent end-stage kidney disease or prolong the time for renal replacement therapy. The problem, however, in removing race is, Black patients, again, were classified in the lower GFR categories quicker. This actually may cause medication dose reduction or discontinuation. And we know that ACE and ARBs are renoprotective early, but they also can cause a little bit of problem in the end-stage renal disease. This also may make patients ineligible for certain chemotherapies because remember, they have to have good GFRs because those chemotherapeutic agents can affect kidney function. So what do we need? We need help from our legislators and the White House. So we do have some legislation that are trying to remove barriers to care for kidney disease patients. Kentucky HB 525, an act relating to community health workers. That is an act that has Medicaid paying for certified community health workers. Remember, community health workers are trusted members of the community. They can actually educate about risks of chronic kidney disease. They can be instrumental in community outreach and helping with community screening. Remember, a lot of community screening isn't linked to referral to primary care physicians. So these community health workers can not only help with the community screening, but they can help with the referral process as well. They also can give structured support, which we know that particularly Black patients like, and they can be involved with advocating for their community. HR 5534 is a comprehensive immunosuppressive drug coverage for kidney transplant patients act of 2020. Before this act, I don't know if you know, Medicare would only pay for 3 years of immunosuppressive drug therapy post-transplantation. The problem with that is, what about poor patients who can't afford those drugs? They're very expensive. As you well know, when patients have to choose between their medications or food or housing, they're not going to choose their medications. So this act actually covers now the immunosuppressive drugs for the life of the transplanted organ. HR 1255, the Living Donor Protection Act, that act has not been put into law at the federal level, but a lot of states are actually putting that law into effect. And what that does is it prevents discrimination in life, disability, or long-term care insurance. So it's trying to remove a barrier for people who want to be a living donor, but maybe have concern that it's going to affect their life insurance. The problem with this is poor people don't really get a lot of life insurance policies. But so that might increase disparities in living donation, but it does remove one barrier. Another thing is the Advancing American Kidney Health Initiative. This was brought into act in 2019 during the Trump administration. It aimed to reduce the number of patients progressing to end-stage kidney disease by 25% by 2030. The problem with this initiative is that's all it is an initiative. There's no money really attached to it to help with education, outreach, etc. But we should actually aim for these initiatives. Another initiative within this Advancing American Kidney Health Initiative is to increase home dialysis and organ transplantation in new end-stage kidney disease patients by 80% by 2025. Only 13% of patients currently utilize home dialysis. And during the pandemic, those traveling to a facility for treatment were 4 times more likely to be hospitalized for COVID-19. So it is an initiative that we should get patients more into their homes. When they're in their homes doing their dialysis, they can do it more often. They feel better. They're more productive citizens. They can work. It's hard to work when you have to go to an in-center facility 3 times a week for 3 to 5 hours at a time. This gives them more autonomy in their treatment. It also wants to double the number of available kidneys for transplant by 2030. In 2021, there were 34,813 deceased donor transplants and 6,542 living donor transplants. There were 97,355 people on the wait list for kidneys. So you can see that we don't have enough kidneys for the amount of people that need them. Between 2020 and 2021, there was about a 1,000 person donation in both deceased donors and living donors. And if you multiply that across 10 years, we're still not going to be reaching that double number of available kidneys for transplant that this initiative is asking us to reach. In this Advancing American Kidney Health Initiative, they do have an incentive. It's an optional care payment model. They will give money to healthcare providers who actually encourage their patients to get on preemptive transplantation list. So there are some things out there that are trying to help us with this problem with disparities and transplantation. We also have at the state level some chronic kidney disease task forces. Some states have initiated these. They advise the governor on the disease and comorbidities. They help to implement cost-effective plans for chronic kidney disease. They educate healthcare providers, particularly primary care providers, on prevention, early screening, and management. They try to involve community health workers because, again, we talked about how those are people that are actually in the community. They're known, they're trusted. And, you know, they also, some of these task forces have created chronic kidney disease registries. And these registries have the potential to improve care for these minority populations. They do microalbuminuria monitoring. They make sure patients have prescriptions for ACE or ARBs, and they make sure they're taking them. They make sure that patients, excuse me, aren't taking any nephrotoxic medications. They make sure their immunizations are up to date. They make sure that they have nephrology consults and they're going to those appointments, and that they have actual planning so that they have permanent access placement and referral to transplant. So basically public health. Okay, so what else do we need? We need money. In the last 40 years, there has been no meaningful breakthrough in changes in chronic kidney disease. In 2020, the NIH, through the National Institute of Diabetes, Digestive, and Kidney Diseases, spent less than $20 per kidney patient on research into kidney disease. That's less than 2% of the NIH funding when chronic kidney disease takes up 20% of their spending. We need public awareness, we need outreach, screening, early detection. We need these patients to get into the healthcare system early. We also need to study racial disparities and what mitigating factors we can have to stop the disease progression, increase transplantation, and get patients into their homes for better treatment options. One thing I wanted to talk about was population health issue. So in 1996, the Indian Health Service noted that their rates of kidney failure from diabetes was astronomical. It was off the charts. So they wondered what they could do to bring that down. So what they did was they created a routine lab reporting of GFRs. They had annual monitoring for microalbuminuria. They made sure that patients had prescriptions for ACEs and ARBs. They had clinical education programs and tools that were culturally relevant to this patient population. And their electronic medical record had population-based management tools, which included patient registry for chronic kidney disease, health information exchange to make sure hospitals and practices were talking to each other, risk stratification for these patients. They had automated outreach so people didn't fall through the cracks. They had a referral tracking system. Not only did they get the referrals, but they made sure they went to their referrals. They had patient portals so that patients were more involved in their treatment and care, and they utilized telehealth and telemedicine. We also have to make sure that health literacy is considered when we're developing these tools. But what the Indian Health Service found in 2013 was that after they initiated all of these things, they saw a significant drop in the rates of kidney failure from diabetes. So it can work, it has worked. We just need to have the will to invest in public health. So what do we need? Also, primary care physicians are the first line in identifying chronic kidney disease. Some of them, however, think it's very difficult to explain chronic kidney disease to those patients who they think have a low health literacy. However, it has to be done. And a lot of times primary care physicians have their clinics so full that they don't have a time to sit and talk about treatment options, getting an access, referring them to nephrologists. But this is an area where maybe a nurse practitioner can come into your office and be that person that can do all of this education. Also remember that patients prefer physicians who share their same race and ethnicity, but only 5% of physicians in the US are Black. And that may be why we can't get these patients in earlier to see a primary care physician. Also remember that early referral to a nephrologist decreases their morbidity and mortality. However, only 3.8% of nephrologists are Black. So we must diversify our medical and nursing professions. We need early education. Black people, we already know, are considered a high-risk group. So we need to get out in the community and get them into the system. They lack knowledge on treatment options. And a lot of times that's because they crash into dialysis and they're so sick that we don't have time to talk about their options. And then they get discharged from the hospital and ended up in an in-center dialysis unit. And we forget to talk to them about their treatment options. So we must make that one of our education priorities. These patients have poor access to living donor kidney transplants. We need to do a better job of educating the general public on the fact that you can live without one kidney, and the benefits that living donation has to patients and their quality of life, and even actually extending their life. These patients want increased autonomy, and so talking to them about their treatment options can help with that. We forget that you can do dialysis in the home, and in the home you can do home hemo or home PD. You can be on a preemptive transplant list. You can do a living donor. There's so many options. We just have to give them some autonomy to participate in those discussions. They want to achieve goals and milestones, and we need to help them do that. A lot of times they think about being on dialysis and they think that's the end of life. So we need to make sure that there are options for them that, people can live on dialysis for, the average is 5 years, but some can live 15, 20 years on dialysis. But transplantation is the goal for all patients. And we need to address the psychological well-being of these patients. There's a lot of depression in these patients. They don't know what tomorrow is going to bring. For those patients who are in-center, they have to come in and they have to give up all their autonomy to somebody who's putting them on a machine and has to watch them and make sure they live through their 3 to 5 hour treatment. They suppress symptoms of depression because there's a big stigma in seeking help for this patient population. They have a bleak outlook on future, and we don't really help with that when we say, oh, the average lifespan is only 5 years on dialysis. Well, that right there just kind of depresses you right off the bat. And they have a reluctance to accept better diagnosis and treatment. Patients with depression are more likely to skip treatments, more likely to be hospitalized, not follow treatment recommendations. A lot of times we call this non-compliance, but most likely it's their way of trying to take some of their autonomy back in their life. And this was a study that was done with the involvement of family members. They found that the benefits of involving the family members was it actually decreased these patients' mortality risk. It enhanced their quality of life. It actually improved their self-management of their chronic disease. They had better psychosocial adjustment to their treatment and less complications because of their treatment, and they had less depression. So more studies need to be done about involvement of family members, particularly of Black patients, and how that benefits them and their decision-making and their ability to participate in their plan of care and their options for care. So as you can see, this is a public health crisis with chronic kidney disease. We have a lot of disparities still that we still need a lot of research into, but hopefully this helped you understand chronic kidney disease. And I am open to any questions. Well, thank you everyone for attending.
Thanks everyone for attending. It was a very great night, and we hope you join us on our next one.